ازيكم جميعا منورين. احنا هنبتدي 9 شرط ان شاء الله في خلال دقيقتين. لو حد ما عداش على البري اتندنس كويستشنير، في كويز صغيره كده ممكن يسكان الكيو ار ونبتدي قبل ما نبتدي ان شاء الله. Okay, good morning, everyone. How are we all? Are we all Arabic speakers? I'll keep formality. I'll speak in English, but if there is any Arabic jargon in the middle, pardon me in that. So good morning, everyone. I'm Mohammed Abul Wafa, and I come with the common name of Wafa, so you can call me Wafa. And I am one of the neurologists who happen to work in between 3 different countries, between Egypt, Italy, and currently working in the UK for the last 5 years. And I have a special interest in neuroimaging and cognitive neurosciences. And obviously I'm here with you today because of my interest in neuroimaging. This practice course, this practice teaching course is very, very down to practice. And it has been allocated to only 25% of its allocated time. So ideally, it should take about 8 hours. And we will have to run through that in a matter of 2 hours. So we will have some tweaks in the middle just to make it happen without a delay. And the things that really make me passionate with this particular training course is the content here has been developed over the last, let's say, 5 years. And it has been very, very, very practice-driven. It was based on proper problem solving. I have been running this teaching for the last 5 years. And every now and then I got in touch with colleagues in different countries and different cities, and through that particular experience, I had a bit of idea about what particular problem might happen, what are particular pitfalls, and out of interest, this is very much Middle East style of practice rather than to be a standard form of practice. So there is nothing that you're going to see today that you're not going to, that you find it difficult to practice next day in your clinic, next week. And it is, again, there is no much knowledge, there is no much new content or new information. Or what you're going to see, this teaching is meant to be a visual training. And so that's why time really matters in this teaching. So an 8 hours means triple the value because it is mainly a visual training. So, but we will definitely try it together today. And it's also about clinical judgment. And by clinical judgment, I mean, it's not just the imaging finding. It is how you would interpret and integrate these clinical finding or radiological finding into making a coherent clinical hypothesis and a coherent diagnosis or a treatment decision. To my very humble experience, this is the most difficult part of imaging practice, and this is the finest skill you can tell, is to tell when the scan is going to give you an answer and when the scan is definitely not the answer. So I hope you had run through the pre-questionnaire. So it has 4 quizzes for you to go through. I'm going to pass through the quiz questions as we go on with the teaching. And I would like you to scan this QR code. This will contain the handout. We prefer to keep it online version because it's colored and contains scans. So you might want to keep it. And in the same link, you will find the presentations for this lecture. I'm very happy for you to use it for educational purposes. And feel free to use them. Okay, so I will start straight away with a visual presentation. I have built this 2 hours in pretty much feedback driven by the feedback I received from you. Most of us wanted a high focus into the visual presentation, to a lesser extent to the hemispheric presentation, compared to the other 2 lectures. So I'll be very, very slow in the first 2 lectures, and I will be very fast in the last 2 lectures. So we will be a little bit slower in the visual presentation, and the pace would build up as we go on. The problem with a visual presentation is that it is a famous presentation, let's say to say it so, but it is a very first symptom in only 20% of cases. And once you made a diagnosis, so as you try to approach the diagnosis with a visual presentation, it's very much imaging dependent. But once you made the diagnosis, imaging of the visual pathway is not a big deal. So if you had a visual relapse, you would not build too much into brain scans. And I think for me, the most important thing is that the visual presentation is one of the very, very, very common to be misdiagnosed. So imaging interpretation here is a skill. And again, clinical judgment is an important skill. And if we list down all the possibilities for a patient presenting with an acute unilateral visual loss, so you would notice some discrepancy here. So MS, among all the other possibilities, is not the commonest. So it's not if you are presented with a patient who had a visual presentation, an acute visual loss, it's not too much that is going to be MS. But once you're confident that this is an inflammatory optic neuritis, it's very much would be MS than other thing. So MS is not the commonest, to say it so, but if it is an inflammatory, it is the commonest inflammatory. So I think our rule is 2-step. First is to make sure that it does not belong to the base of that pyramid. Once it's there, the likelihood is going to be higher. And this is how I personally do it. So when I first present with a patient with acute diminution of vision, the first thing I would like to check is to, Okay, so definitely history taking is essential here, simply because the most common misdiagnosis for an optic neuritis is migraine. So migraine is a historical diagnosis. And second, is it actually neuro-ophthalmological? Is it something to do with the neurology department rather than the ophthalmology department? And that warrants an ophthalmology referral initially. And where exactly does it lie? So once it's neurological, it's pretty much my job. It's where is it along the visual pathway? That's pretty much the next 20, 30 minutes of this presentation. And once I localize that to the optic nerve, is it actually inflammatory or not? And there is a diagnostic criteria for optic nerve, very much underdog publication, but very, very, very relevant. We'll come to that on a point. And once it's inflammatory, once I confirmed it's inflammatory, there is a very high likelihood this being MS. And it's easy to rule out other possibilities with fluid biomarkers and infection and other inflammatory biomarkers. And that's the diagnostic criteria in a nutshell. So you would need to have acute pain, mildly painful loss of vision. I think most of us are pretty much knowledgeable about it. And if you don't have the typical presentation, you would need to have the criteria switched to a very specific criteria needs to be met between clinical and paraclinical. Now, let's turn to what we are here for today, which is the MRI examination of the visual pathway. Here is a very interesting paradox. So the atlas, so when we learned functional anatomy, being a neurologist, particularly for that part, how many radiologists are we are? Okay, brilliant. Okay, so here's how the neurologists learn it. So then we learned that in one simple cartoon, starting from the eye, ending with the calcarine sulcus and of the visual cortex. That's not how it looked like in the scan. And you would know how to look into every different segment in an MRI scan. So in every single stage, we will divide the stage of the visible pathway into 3 different components: the orbit part, and the cellular region part, and the central pathway. And in every single stage, there is a dedicated modality to scan, and there is a delicate anatomy that you need to understand, not just the visual, the neurotissue, but also the surrounding tissue. And more importantly, in each stage, there is a dedicated sequence and a dedicated anatomical plane for you to look for. So let's starting with the optic nerve. Once you start to identify the parts of the optic nerve, you will be able to very nicely visualize it. So optic nerve starts with the papillary part. That's the inside the eye. You will need to make sure that it is flat, and then there is the retroorbital part, retrobulbar, sorry. And then there is a bony canal encasing the optic nerve. And once the optic nerve passes out through the bony canal, it's inside the intracranial compartment. There is a short segment before it joins the chiasma, and there is an optic tract right after. So simply, we will look into that, into brain scans. That's my preferred way to go for that. I picked up an axial scan, and I'll start from the very bottom, from the inferior side of the scanning volume, and I will go slightly upwards as I stand up. So we start with that very much void space. That's the maxillary sinus filled with air. And this is actually the floor of the orbit. If there is any pathology coming downwards from the bony orbit, you would start to find some irregularities here. That's a normal scan, so you wouldn't find something. Now we will start to see the orbital compartment. So there is, of course, there is an eye globe, and there is the tip of the bony part here, is right here, and it shouldn't be exceeding the front. The eye shouldn't be proceeding 50% beyond that line, because otherwise it would be proptotic. Once you're reassured about the eye appearance, eye position, and sometimes it's eye alignment, they are both aligned, and then you would look into the intraocular compartment and make sure that the back of the eye is flat. That's reassuring, nice, solid line, so I have no issues with that. And because we are starting from the very bottom, that particular band is a straight band, as you can see, and here is just another straight band. That's inferior rectus. Okay, as we travel slightly up, we'll start to see the other intraorbital muscles. So, and the content of the orbit in this particular slide is hypo-intense. It's because that's a very much dedicated scan to the orbit. That's a stir, and we will come into that detail in a bit. So that's a middle part. This is the pride. This is the optic nerve, as you can see it, and that comes only, if you notice, is just only in a couple of slides from the whole volume, from the whole axial volume, and that's a particular important fact we need to consider here. But for our purpose, let's look into the retroorbital part. The retroorbital part starts with the nerve. The nerve is not a straight line. So this is not a muscle. So likely the nerve would be slightly undulant. That's one thing. And the second is it's surrounded by CSF space. And the CSF space, guys, normally is a little bit wider just behind the orbit. So it's not an IIH presentation. For an IIH, it would be likely spread through the whole retroorbital part. So it is normally, you would find that part slightly dilated compared to the back, the posterior part of the optic nerve. Fine. And this is lateral rectus, medial rectus, no rocket science, and that's the lacrimal gland. Lacrimal gland, it should be on the outer part, start to show up because the lacrimal gland is higher up, so likely we're going to contemplate that better in the next slides. But here's the fact, the optic nerve disappeared. So there's just 1 or 2 slides in a very much dedicated axial slide. So, and that's the lacrimal gland. Rest of the orbital tissue is fine. You would find a very nice superior rectus, and that tiny structure is a superior ophthalmic vein. This vein tends to be much dilated in intracranial hypertension and in venous abnormalities. And later on, so there is, now we have checked 2 parts of the optic nerve, the intraocular part, the retroorbital part. The most difficult to see in an MRI is the canalicular part, and it's the most vulnerable part of the nerve because it's surrounded by bones, and any edema, any inflammatory infiltrate would end very, very high risk of losing vision because there is no space for swelling. So how would I see a bone in an MRI? The answer is I would not. So actually it isn't, but I do know that the anatomy, so once the intra-orbital part is done, there is a straight line here, and there is a dark void sideways. This is actually the bony canal. It's important that at least you pinpoint your eyes into where exactly the bony canal is and where should I expect the intraorbital, the intracanalicular part. If there is a pathology around here, I would expect the patient to have much of a functional loss. If I'm suspecting a pathology here and the patient visual acuity is fine, I would suspect a diagnosis and I would refer to a more dedicated bony imaging, ideally a CT scan, for example, to contemplate this further. And once it emerges from the bony part, it's the intracanalicular part, as we can see here. And here is the intracranial part of the optic nerve. So that's intraocular, intraorbital, canalicular, intracranial, and then the chiasma. Chiasma is anterior to the pituitary. Very simple anatomical fact, very much easily to confuse in brain imaging. So here is the pituitary stalk, and that little X here is a chiasma coming from the intracranial part of the optic nerves, merging in front of the pituitary, and later on it will transform into the optic tract. So here is another fact. So we were here slightly inferior. So if you slide up, you would bypass the pituitary stalk. So you are in the 3rd ventricle level. That's the 3rd ventricle. That's the mammillary bodies, if you are an anatomy geek. And rightwards, both sides, that's the optic tract. And the optic tract aims to terminate into lateral geniculate body. Lateral geniculate body, let's be practical, it's part of the thalamus. So this tract is going backwards, upwards, because it will merge into the thalamus, and it will, because it is lateral, it will merge into the thalamus from the lateral side. That's the lateral geniculate body, medial geniculate body. And that's where exactly this peripheral part of the visual pathway terminate. Okay, so I told you that we are looking for the optic nerve, and we were only lucky to see the intraorbital part into just a couple of slides. So that's a shame, because we are looking into the wrong plane. If you would like to see a proper retrobulbar optic nerve, you would need to switch to an orbital plane. I personally call that the salami rule. So if you want to cut a salami in a nice way, you would cut it in transverse rather than you would cut it in length. So let's see, that's the eyes, spooky. So it'll pass through the eyes. It's important to check that in the outer side there are the lacrimal glands, and there are 6 pairs of muscles on either side, they closer to the attachment. Also, in a coronal plane, you would like to ensure that the nasal pathway or the paranasal pathway is intact and the walls are intact, because sometimes pathologies just jump into it. And here we will start to see the retroorbital part. What I need to compare is 1, neural tissue, 2, extraneural tissue. Neural tissue, we would need to check for signal, hypointense, symmetry looks the same, and any gross abnormality around it. That's start with the fat surrounding the nerves. Here, that's a fat suppressed sequence. So the fat, a normal fat, would be suppressed. Anything unusual would be bright into this signal. If I didn't see something, that would be definitely a normal appearing fat. So for example, that's a parotid and that's the subcutaneous fat. All of them are suppressed because this is a normal fat suppressed sequence. Okay, so that's as you go backwards, the cone of the orbit start to get narrower. You would start to see the muscles getting closer and closer until you would reach to nearly the orbital apex. And at the orbital apex, you would start to shift to the ciliary pathway. That's the second one. Again, in the ciliary pathway, you would need to still look into the coronal plane. That's intracranial part of the optic nerve, right posterior to the apex. Intracranial part, they will get closer, so they were wide. Now they are getting a bit closer. Let me take off the pen marking, and they will come closer, 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 and then they would merge into what is a partial volume of the chiasma right in front here and right in front here. So, and importantly, they are just below the inferior surface of the brain. So it's the first structures that emerge right below the brain is that optic nerve, the intracranial part of the optic nerve. Okay, and you still need to in the cella, because the cella is a very tricky, very special, very sensitive part of the brain, of the head. Let's say we would need to look into the 2 planes. You would like to make sure that our favorite cavernous sinus looks right in close proximity, and the intracranial part of the optic nerve, we spoke about that. So for our own purposes, and just for the sake of time, enough to say that the cavernous region, the paracellular region, let's say it so, is equal in terms of size, and it has a concave outer border. That's not a suspicious looking cavernous. Once you start to have a suspicious looking cavernous, you would have a completely different pathway, but you would like to ensure you are okay with that. So that's, and it just absolutely looks fine. Again, pituitary stalk, chiasma is in front, and then you would continue with the rest of the brain. And let's jump off to the central pathway. Central pathway is easy. We pretty much see brain parenchyma all the time, so it's a bit easier than contemplating the intracranial and the skull base. But still, you would need, axial plans are ideal. You would just need to familiarize yourself, identify the different parts, the lateral geniculate, radiation, and the visual cortex. And axial planes are fine, but you would use 2 different sequences ideally. Okay, so now we are, that's what looks like the lateral and medial geniculate around that part. They are not midbrain, so that's how I localize it, to be honest with you. It's just I wouldn't wait until it is very much delineated, but it is definitely above the midbrain and below the propothalamus, the 2 egg-like part of the thalami is not visible yet, and it is the slide below is simply the start of the diencephalon, or the start of the red nuclei and the cerebropeduncles of the midbrain. So that's actually where the attachment of the optic tracts are. And then that's propothalamus. We have no problem with that. And here is a very nice anatomical fact that I have to memorize well in my early years of neurology practice. There is a von Willebrand lobe that runs here, there, this way. So this is where the optic radiations should lie. So let's transform that into a radiological landmark. So here's that part of the brain, or let's start with that part of the brain, is a triangular part, and that's called the trigone. The trigone is the part of the lateral ventricle when it starts to form the temporal horn of the lateral ventricle. So that trigone actually have that loop of visual pathway. So supposedly, if you had a lesion here, the patient would be visually impaired. That's not a temporal lobe lesion. It's practically, anatomically, it is a temporal lobe lesion, but it's a temporal lobe with a compromise of the visual pathway. And that's important to match clinical findings to a radiological finding. Okay, so again, so that's the, sorry. So let's go back. Ideally, that's a bit of a detail, but let's just go through that. The denser the white matter fibers in the brain, the less water content, the more hypointense in T2. And the visual pathways, the optic tract, the optic radiation, the optic radiation is one of the densest in the brain scans, in the brain. So you would find it more hypointense here than the rest of the brain, than the rest of the white matter. And guess what? If you would like to contemplate how the cerebral peduncle would look like, so that's hypointense, again, because the pyramidal fiber is very intense and hypointense. So that's the same as well with the visual pathway, and the same with our lovely internal capsule, early residency years as well. Okay, now let's speak a little bit about the pulse sequences. We will, first, you would need to have a highly dedicated scan. So, for example, this patient had post-contrast MRI in the top slide, and it might pass as normal. If you are a bit obsessive, you would suspect that this size is different from that size, but you wouldn't be confident to make a diagnosis. But here you are, that's the same patient. That's the same patient. When you just had a fat suppression, you discovered that the coverings of the optic nerves are inflamed, and there is a surrounding hyperintensity on the post-contrast scan. Is there anything abnormal with the muscles? They look hyperintense in the post-contrast. Do you know why? Yeah, they are vascular thing, but they are not a blood-brain barrier thing. They are outside the brain barrier. One way to know a post-contrast from a pre-contrast T1 or a stir in a scan, pre or post-contrast T1 in an MRI slide, is to look for the structures that normally enhance. In an orbit MRI, that's the muscles, and that's also the nasal cavity. And actually, this is where I tricked you in the pre-questionnaire. So it's tricky. I deliberately made it tricky. It's just to contemplate the fact that this is a T1 sequence. This is not a fat suppressed sequence, and the muscles are not enhancing, nasal cavity is not enhancing, that's not an optic nerve pathology. Okay. Okay, going back, let's quickly go back to, so that's a post-contrast with fat suppression is an essential feature. You would miss a diagnosis of this patient, and the scan would be reported back as normal if you did not have a dedicated fat suppressed sequence. And again, you would have a STIR sequence. STIR is short tau inversion recovery, STIR. Okay, STIR is needed as well in an dedicated orbit scan. This an abnormal signal picked only with STIR sequence compared to an axial T2. Again, if you are obsessive, that's enlargement. It's not just about the signal; it is about the appearance and form. And you would need to look into more than one anatomical plane. So, for example, if you are in doubt, you would be definite that this is an asymmetry in a coronal plane, if you are suspecting that in an axial slides. Axial slides, as I told you, the bride would show up only in two moments. It's just in the whole volume. But in the coronal, you would have multiple slides, and you would be able to make a reasonable judgment. So here is another enhancement. Okay, so let's, of course, ideally, if you are suspecting a neuroinflammatory pathology, there's nothing without a contrast. So presence of a contrast enhancement is a piece of information. Absence of pathological enhancement is another important piece of information. You wouldn't miss that. You are, at the end, you're the person entitled to the diagnosis and the management plan. Don't let this piece interrupt you. Sometimes you may add, if you have a dedicated pulse sequences, upgraded MRI scans, you may have a diffusion weighted, which can pick some ischemic changes in the optic nerves. That's too much of a detail. Everyday practice, have a high field scanner, multiple anatomical planes, dedicated sequences. If you are working with a neuroinflammatory condition, not necessarily an MS, contrast is not invasive, contrast is essential. Okay, so now to MS, it's more likely than not you will end up with a normal scan. That's statistics. So if a patient presenting with an optic neuritis, it's very likely that the odds are more likely that you wouldn't pick a scan. And that's why there has been a hassle 10 years back when the Magnums decided to integrate the optic nerve in the diagnostic criteria, and this was bounced back at the time, simply because of the diagnostic yield was very low. So because you would need to scan 20 patients to pick up with optic neuritis, to pick up 2 or 3 or 4 patients with abnormal findings. So that's a waste of resources. They decided to make haste slowly. In that criterion, guess what? It's now available, but it is not something that you would do routinely without proper judgment of what you need to do. Okay, let's have a look into a patient with retrobulbar optic neuritis. Let's start. That's for the sake of time, I will dodge that part. That's normally enhancing nerve. That's to contemplate. Again, that's a post-contrast, T1 post-contrast. Pituitary is enhancing, nasal cavity is enhancing, muscles are enhancing, left optic nerve is enhancing, orbital tissue is not enhancing. That's important. Okay, so, sorry. Go on. Okay, and again, there is an asymmetry left. So you would compare both sides in an appropriate planes, appropriate sequences, both sides, shape, size, signal, multiple sequences, multiple anatomical planes, different components of the nerve. So you need to identify them one segment after the other with the optic nerve. Okay, let's do some practice. And I will follow this particular algorithm I told you about. And the first part of the algorithm is where when it is neuro-ophthalmological and a migraine, MRI would be quite misleading to you if you missed that. If that's an ophthalmological thing, you would interpret a normal MRI in a certain pathway, you would interpret an abnormal MRI in a certain pathway, and it's all historical, and it's all ophthalmological. So MRI here is misleading, unless you make the proper judgment that this is actually clinically suspicious of an optic neuritis or an optic neuropathy or a visual compromise due to a focal neurology. You wouldn't gonna make much of the scan. And in the middle part, we have lots of literature speaking about abnormal enhancements, abnormal changes in MRI, but they are not diagnostic. And that's, again, a very important piece of clinical judgment in visual imaging. Despite there are some findings, they cannot make a diagnosis. They would help you to confirm the diagnosis through the constellation of other things. They can pinpoint towards something for you, but they wouldn't make the diagnosis. If you found an abnormal enhancement in the paranasal cavity, you would point out that there is an extension and an invasion coming from the paranasal sinus space, but the scan still wouldn't make the diagnosis for you. If you have an enhancement of the optic nerve, you would say that this is inflammatory, but you still need a fluid biomarker to say it so. To tell if it is actually an antibody-mediated or a viral-mediated or a systemic inflammatory-mediated. And at the end, we got a large volume of literature. That's actually where we are on today, is when the brain scans, visual imaging scans, are really an add-up to your asset. Okay, that's a patient with right eye diminution of vision and light perception. What's interesting here is that if you look closer to the scan, so we have a visible, ugly-looking optic nerve here, retroorbital, not extending to the intracranial part. the head is all right, but what's quite striking is that it's not confined to the nerve. It encases the nerve, and it involves the fat tissue surrounding the nerve. This is called fat stranding, and that's a red flag for MS. It can happen with other antibody-mediated diseases like the MOGAD and neuromyelitis optica, among others. So it's not diagnostic for them. It can happen with viral optic neuritis. It can happen with orbital infiltrations. Okay, so that's, again, that's, I think that's a MOGAD patient. It's a MOGAD patient if you have a picky eye, so that's right hemipontine. That's a neuromyelitis optica, right hemipontine, left hemipontine is involved as well. That's proper fat stranding. That's an optic neuritis of an MS, and that's a optic perineuritis in a patient. This patient has a MOGAD, but again, fat stranding rules MS, but does not rule in one single entity. You would need to do a bit of a detective work to pin down what's going on. So for this particular patient, for the MOGAD, the MRI can be really helpful and an add-up. Okay, so that's another patient with bilateral optic neuritis developed in the context of a COVID infection. So just to show you that it's not necessarily a positive finding in MRI. It is something to do only with my neurology textbooks. It can span the width and breadth of medical practice. Okay, so that's a patient with obscuration of vision for the last 5 days, and she couldn't tolerate the lights. She saw a private ophthalmologist who suggested an urgent neurology input. From his point of view, she was clear. And that's her brain scan. So again, I'm starting from the bottom, going up. The optic nerve stretch, I have to say, but it's only in one eye, but the other eye is undulant, so that's fine. Muscles are all right. That's a fat suppressed sequence. Let's have a higher look. So that's canalicular part, nicely seen here. And that's the roof of the orbit. And these are the optic tracts and the third ventricle. So far looks all right. Let's have a coronal plane. Again, size, shape, symmetry, and signal. Looks fine. Fine. And that's her brain scan. That's multiple white matter hyperintensities. Happens with migraines. This patient had a migraine and had a misdiagnosis of MS initially. Okay. Okay. Let's have one final patient. Okay. So let's start with the question. So what does these arrows on the left-hand side scan? What structure does he point to? What do you think? Optic radiation is a central pathway. So that's something beyond the optic nerve. That's absolutely right. But that's something still in the intracranial part. It's not within the brain parenchyma. And so it looks like they are diverging in the outside, and it looks like there is something here in the pituitary. Do you agree with me? Do you remember the fact? Is it a chiasma in front of the pituitary or behind the pituitary? Chiasma is in front of the pituitary. So if this pathology is behind the pituitary, guess what? That's the optic tract. So that's not the optic nerve, and it's the optic tract, and it is bilaterally and symmetrically enhancing. And again, this is closer to the attachment that apparently there is some edema around. It's on its own, without anything else, it's very suspicious of a bilateral optic tract enhancement. But there is an elephant in the room. There is a space-occupying lesion here. So that's a supracellular craniopharyngioma. That's not entirely. So sometimes you may have a patient with visual compromise, and it's actually not particularly, again, the neuroinflammatory textbook. And you would need, unless you have a proper understanding of the different anatomical landmarks and the different anatomical sequences, you wouldn't make an interpretation. Definitely our radiology colleagues wouldn't miss that. Us neurologists who can survive few days without a radiology report would start to give steroids, would start to do the workup and have the CSF examination of a craniopharyngioma. So I will conclude that first session. So sorry if it made a bit longer than it should be. And I told you in the beginning, I love neuroscience and I love cognitive neuroscience. And I'm sharing with you one of the fascinating things that I come to know. And I come to know that colors are a very cultural thing. So let's tell the story from the evolutionary point of view. So from evolutionary point of view, mammals, when they start to surmount the planet after reptiles, they started with a monochromatic vision because they were nocturnal. Later on, because if you need to look for a fruit, for a piece of ripe and unripe fruit, you develop the mammals start to develop color vision. Color vision actually developed closer to the primates rather than to usual mammals. And understandably, red-green desaturation is a ripe, unripe piece of apple or piece of fruit. The unnaturally occurring colors is a bit more difficult to contemplate. And one of them is a blue color. And there is an argument, strong argument, that blue color did not exist a few thousand years back. And this was mind-blowing. But if I'm a Muslim, of course, I'm practicing Muslim, alhamdulillah. And if you go through the Quran, you would be equally mind-blown, because there is no description in the Quran or the Sunnah that mentions the word we use for the blue color, and it actually means a blue color. So the Quranic verse, وَنَحْشُرُ الْمُجْرِمِينَ يَوْمَئِذٍ زُرْقًا, is proptotic eye, or a staring eye. So it's not meant to have the color. It's not about the color. And the very stereotypical example, زرقاء اليمامة, that's a cartoon, imaginary cartoon of a fictional Arabic character that had a very sharp vision, and that was called Zarqa. So Zarqa didn't have blue eyes. Blue eyes is a gene evolved 30,000 years back in a different place of the world, and it wasn't there in the Arabic history, and at that part, a few thousand years back. So that's a little break to Scott. Are we okay to go ahead with the next presentation? Okay? Any 1 minute question? Yeah.
May I come there? I can tell just right. My question, actually, first of all, thank you very much for your comprehensive talk. My question is about how can we differentiate, or is there any possibility to differentiate by the MRI between the ischemic optic neuropathy and optic neuritis? You know that in the middle age there might be very quite similar.
Yes. That's very challenging. Very challenging. In the 8-hour version of this slide, there is a couple of ischemic optic neuropathy patients, but again, you would make a clinical judgment rather than an imaging judgment. When it exceeds I had a case who had a non-arthritic optic neuritis, but the inflammation extended to the intracranial compartment, and that's why we made the diagnosis. So we never made a diagnosis based on an inherent feature. There is some reports of diffusion-weighted restriction, still unreliable, because if you had an inflammation in the canalicular part of the optic nerve, and the nerve is squashed against the bones, you would end up with ischemic changes in a nerve, and it would show up with diffusion-weighted restriction. So there is no imaging biomarker to make a diagnosis. It's only the constellation of symptoms together. One of the things that I have been trained largely as a neurologist, and in a little part as in clinical and radiological and research MRI, but I'm still very passionate to be a neurologist, because in radiological interpretation, it is our job to be factual, is to state what is there and not to state what is not there. If you have a patient with an MCA symptom in 30 minutes, you would do a CT scan. If you're playing the clinician role, you would say this is a stroke. And if you swap yourself to do a radiologist role, you would have to say normal appearing MRI or normal appearing CT scan. What's really fascinating about neurology is that we are hypothesis testing piece of geeks. We need to generate a hypothesis. This patient has this and that, so he needs to do this. He has this diagnosis. And this is what is really meant for clinical judgment. So in a clinical judgment, you would have a hypothesis. You're not stating facts, but you're taking decisions. And of course, understandably, we are all clinicians. This is concerning our patients' lives and well-being, and that's important to integrate different bets together. So while making a radiological interpretation, you would need two steps. One, to be factual. Second, that's why neurologists still interested in neuroimaging, we would need to apply an analytical point of view and a hypothesis point of view to the scans, which would be highly unfair to be left to a radiologist left with left eye diminution of vision for MRI scan. So that's very difficult, because the left eye diminution of vision is actually one of my migraine patients that has been diagnosed with MS for 2 years, and left eye diminution of vision is an ischemic optic neuropathy, and I suspected that as Monjaro, so Monjaro causes optic neuropathy, yeah, it's cheeky. Okay, so you're all experts. If you attend this lecture, you had a good years of practice. Most of us actually, in the pre-attendance questionnaire, most of us has 10 years plus years of practice. So can we swap to the presentation, please? Yeah. Brilliant. So intuition, switch off your logical mind. Okay, which one is MS? Left. Yeah, that does make sense. So why it is left, let's start to identify and make a reason, make a rationale. Periventricular, yes, both are periventricular. White matter lesions, yes, both are white matter lesions. The only exception would be this one is slightly fluffy and the other one is not, but subcortical lesions, so what? Subcortical lesions do happen in MS, so that's what. So the point I want to make from that slide is that we have a set of identification points that overlap with pretty much most of the white matter lesions we do see. This lecture aims to integrate one important piece of visual skill training, is to navigate through a pattern that is very consistent in patients that happen to have MS, patients that happen to have demyelination. That's not a diagnostic criteria driven, it's very much anatomically driven, and it does absolutely make sense. And that's the two main problems with white matter hyperintensities. They are frequently silent in MS, that's why we use them for follow-up. The chance to have a relapse compared to a new white spot is 10-1. That's why we use them in clinical trials, spares the money, spares the effort, spares the number of recruited patients, and but they are frequently non-specific. From a diagnostic point of view, it is a highly challenging thing. But once you made a diagnosis, your life is much easier. Okay. So let's say the following hypotheses I'm going to tell you do refer to me. They're not universal in terms from a very much educational and teaching point of view. This is not an agreed upon hypothesis, but this is my way of doing it. This is my understanding of how MS pathology happens and how imaging interpretation happens. And I call any given pathology that there is an entry point theory of brain disease. Any disease that happens in a brain needs to make an entry, and there are very simple three facts. One, we need to understand the entry point. Two, early in the disease, you show the sensitive signs, no rocket science, and later in the disease, you'll show more of the specific signs. There's nothing interesting about this very simple fact, isn't it? So it's just very simple. But if you start to apply these simple facts into different pathologies, you would make your life would be really, really, really easier. That's very simple facts. So every disease in the brain is very privileged. Every disease has to make an entry. And through making this entry, early sensitive changes, late specific changes. That's all what it is. And for the entry of MS, we do know that pathology starts around veins. And this is known since more than 100 years back. So that's a very consistent feature that lymphocyte trafficking happens around veins. But that's not particularly specific for MS. Every single pathology or inflammatory infiltrate usually happens in the post-capillary venules. So when you have a slow flow and you will have less of the tight junctions and more of the chemoattractants start to show themselves in the post-capillary venules. There is another interesting and a very appealing thing about lesions in MS. Lesions in MS tends to occur in three particular regions. One, that's the juxtacortical region. Two, the very ventricular region. And three is not shown here in the subpial region of the brainstem and in the spinal cord. There is a reason for that to think about it. So the flow, the laminar flow of the blood needs to be slow for immune cell trafficking. And that essentially happens in the venous side. Two, there is particularly, this is because of the inherent anatomy of the brain. If you notice here, there is a very sharp turn to the veins as they traverse to the subarachnoid space or traverse to the subependymal periventricular space. There is an acute angulation to most veins around this region. So that's why I call that an immune traffic damping theory. So, and it's pretty much known in the fluid dynamics, in fluid hydrodynamics. So, for example, we know the plumbers, sorry, so plumbers know that there is a turbulence around these points, the turning points of the pipes. So if you imagine the wall is a brain, and you imagined this pipe as a vein, there is a little turbulence here, and that's where MS lesions do happen. That's actually where angulations start to show themselves and start to develop MS lesions around these entry points. Regardless, that's one way to interpret it. Okay, so that's not necessarily the correct way. There are very much theoretical undergrounds in that. I wouldn't get you into this detail, but let's, for our own contemplation, this is at least one way to think that MS pathology, when it happens, it needs to happen persistently and in more abundance into that particular regions. Can happen anywhere, but it tends to focus around these parts. Okay, and so that's point one. Point two, if I tracked, this is common sense, if I tracked the veins within the brain parenchyma, I would know where MS lesions should be. MS lesions align through a long axis of a vein. And if I know where the vein is, I would localize the vein. I would localize the MS. I would diagnose and make a diagnosis of MS. One fancy way, 3T MRI scanner, SWE imaging, susceptibility weighted imaging, T2 star in 3D, and you would have a proper contemplation of a vein and a lesion, and you would conclude a central vein sign. However, life can be much easier, or sometimes in the usual practice can be a bit easier. Let me tell you something about the development of the brain. So the brain starts with a little clump of tissue in the embryo. And as we grow on, the brain increase in size. And this pulls on the neural progenitor cells, the scaffolding cells. So all the cells migrate from around the ventricle to the mantle of the brain. And as the brain grows, it tracks its own blood supply, arterial feeders, venous drainers. So you would end up with the three structures running together. So there is usually, within the brain, you would have a nerve fiber tract, a vein, and an artery running in close proximity. And there is an easy way to tell it. This is my way of doing that. That's a T2 spin echo. Okay. We do happen to know that there are some patients, or some people, have a dilated Virchow-Robin spaces. What are these spaces for? They have a glymphatic pathway, well and good, but they have a vein and we have an artery. And if you track visually where normally the perivascular spaces are, which are quite visible in a T2 scan, you would be able to pick up where the lines, the long axes of MS patients, of the lesions of of MS. So on your left-hand side is a patient or a normal individual with dilated Verkau-Robin spaces. And on the right-hand side is just the line markings of these lines. Every single line, the main rule is that every single spot on the surface needs to go back to where it come from. So me, living in London, I have an irresistible feeling is that I need to go back to Cairo, Nas City, every now and then. So that's what the veins does, what the nerves does. So that they travel from the ventricle, from the cortical mantle, down towards the ventricle. And they need to do that in the easiest, shortest path, in a smooth line, without any hard lines. So that's all, simply this is what it entails. In the top of the brain, above the lateral ventricle, so these superior, middle, and inferior frontal gyri, they travel backwards and toward the ventricle point. Again, this happens here. In the middle part of the brain, they start to go traverse towards the alma mater, the periventricular space. Let's see, for example, on the left-hand side, this is an MS patient. There is nothing specific on the scan on the left, but it is just to contemplate that this lesion long axis aligns with that fact. And here is few more lines. The rule is very simple. They follow the finger projections or the finger likes of the cortical mantle traveling to reach the periventricular space. Again, these are few lines here, and that's irrelevant, just a cortical lesion, but just for that. And importantly, as we start to go closer to the ventricular surface, there are two important facts. So one, the fiber starts to align rather than from front back, they'll start to traverse in the transverse direction. So that's where these lesions are. And they will start to show a little bit the start of the corpus callosal fibers. They will start to show some forceps pattern here, around here. So the lines would not extend in a straight line. They will start to curve as we travel down. Let's have a proper look for that. For example, you'd find that long line is going this way. Let's have a look into, let's grab an MS patient on that part. Or I'll tell you what, let's contemplate an MS patient versus a non-MS patient. Again, that's intuition works. It's the MS is on the right side, the left side is ugly and doesn't look like MS. But let's contemplate that fact we have been discussing now. Here is a line of the forceps. Here is a line of a forceps. Here is a line of the forceps. Your brain already knows that fact. Simply, your conscious mind does not identify it. Now you do. So we know, we have an intuition that this is MS because the lines are making sense. Even if we didn't verbalize that out. But now, once you verbalize it, you would be able to localize it in an efficient way. Let's try the same with a non-MS patient. So that line, I'll say, okay, but that line doesn't. That line doesn't. And so there are plenty of lesions here. None of them speak out MS yet. So none of them speaks out the forceps minor or the forceps major, let alone the disastrous subpial enhancement, which is a red flag in MS. Okay, that's again MS lesions, right and left. MS lesions. There's no difficulty in picking that up. I'm just grabbing them just to let you contemplate how it would work. And now even for the dirty appearing white matter, there is a pattern of forceps curve around here. And the same applies even with extensive white matter lesions. Here's a forceps pattern. And we will, in a few minutes, we will contemplate that against non-MS patients. So again, with the proper corpus callosal sections, when you had the genu and the forceps major around here, you would see plenty of MS lesions around that place as well, and they ideally would follow that particular line. This line is different from the vascular line. Vascular line, that's where the ACA territory is, that's where the middle cerebral territory is, and that's where the posterior cerebral territory. If we would like to contemplate a vascular territory pattern, likely you would find earlier finding in these lines rather than the MS forceps lines traveling this way and this way. That's simply how it looks like. Particularly, and it's very relevant, when the pathology speaks too much, you would be able to tell. If you have plenty of lesions, you would be able to tell. If you have 1 or 2 lesions, your life is hard. But if the pathology speaks a volume, and it still didn't show specificity in MS, that's very much of a red flag. Okay. Let's, again, same applies as just a couple of slides on the temporal horn. Again, the rule is simple, as everything tends to go back to chironicity. Lateral ventricle. All the points tends to find a smooth line towards the lateral ventricle, and these are all the lines that you would contemplate. That's a couple of MS lesions around here. It depends. Does anyone have a problem with a red line? Are we all happy with a color-friendly red line? So that's obviously not an MS patient. Sometimes it's difficult to tell, but in overall, we will come to the brainstem in the next presentation. But it's difficult to tell only from 1 or 2 slides. But again, the long axes, most of the lesion, that's one might fit, but not the rest, and that makes me not very much confident around it. And also, usually MS tends to involve the temporal lobe in more abundance, but they tend to involve more of the temporal horn compared to the neocortical part of the temporal horn. And one very important fact, actually, is that let's say in a migraine patient, so the non-specific white matter thing happens in pretty much the top part of the brain rather than the base of the brain. So it tends to happen in frontal and parietal region. Very, very, very rare to involve the temporal lobe, particularly if alone. There is no non-specific white matter lesion that happens only in the temporal lobe. I can have few of the white matter spots on the temporal lobe only after I have a 10 up there in the temporal, in the frontal and the parietal lobe. So that's one thing to get you the gist of things. And we do know that MS tends to involve the basal part of the brain. One of them is that the immune trafficking damping theory I'm telling you about, but there's one thing about the effect of gravity on the fluid biomarkers and the chemotoxins and the cortical demyelination always happen in the basal part of the brain. So if you are very much trained to contemplate well the temporal lobes, you would pick much of the specific MRI changes in MS. So, and here's simply, in a nutshell, there's early versus later changes according to the simple entry point theory. So entry point theory, point 1, we need to track the veins. That's simply put. We have a clinical early change, a patient presenting with the first episode of an optic neuritis in a young onset, so that's early change. But we also have a radiological early change, a patient with 1 or 2 lesions. So that's a radiological early change. And they would need to show some sensitivity into that. And later on, 10 years history, a couple of clinical episodes wide apart, one 10 years back after delivery, and again today was a partial myelitis, so that's a very long history, clinical history. You would need the specific signs should have been picked up by that stage. 10 years of MS, likely, very much likely, you would have bands positive. You would very much likely you would have a pearls, paramagnetic rim lesions. You would have more of the specific changes. And more importantly, time, dissemination in time, is actually a criterion that is meant to show some specificity. So if you wait for 6-7 years to be more confident about the diagnosis, you're adding more specificity to a diagnosis, but we pretty much trying to avoid that in the last 6 versions of the criteria. Okay, so that's how it works. What's early in MS changes, is that was the sensitive signs, is that, of course, if you have an abnormal MRI scan. If you have a patient with an optic neuritis and a normal brain scan, that means it did not show the sensitive sign. So that's why the conversion to a clinically definite MS is very low in an optic neuritis with a normal brain scan. So it's to have any abnormal brain scan, that's a sensitive change. To have a central vein, that's because simply you would need to have the proper sequence to pick it up, but it is there, and it's always follow a vein. From a pathology point of view, it never live without away from central veins. And there is much higher chance to find more of a lesions around the ventricle. Again, this, I think, to my personal opinion, is relating to the fluid dynamics of the veins rather than to anything else. And in the later MS changes, you would need to show the specific signs. What are specific signs? Dissemination in time. And the lesion burden topography. If you have 50 white matter lesions, none of them speaks MS, that's not usual, because MS tends to happen around veins, and if it happens around veins, it would show to the typical locations, which follows the typical trajectories. If it didn't happen 50 times, so you throw the dime 50 times and never come with a 6, so then this dime is rigged. So this dime doesn't have a 6. So that's as simply as that. If you have a high burden lesion and none of them is very specific, you didn't find a specific sign, that's not MS. That's as simple as that. Some lesions are more specific than others. So, for example, the temporal lobe lesions, we spoke about that. Brainstem and spinal cord lesions, we will come to a very fascinating brainstem patterns in the next presentation. And recently, a paramagnetic REM survived much and reached the criteria compared to other things. If you read an MS, and if you have been a good reader in the last years, you would have picked up that, for example, we had the rise and fall of double inversion recovery. Double inversion recovery is very appealing. Once you make a diagnosis, it's useless. You never use it to follow up an MRI patient in a follow-up. Second, it's highly plagued with artifacts, and it tends to show lots of false positive, and you need a person who's really, really trained to pick up your cortical lesions. It's very technically demanding. That's my personal experience. I have been working with a group of neuroradiologists in East London, and they are brilliant. We never made a single diagnosis based on a double inversion recovery alone. So if I'm suspicious with a double inversion recovery, I would complement with a 3D volume of a flare, 3D volume of an MP range to make a diagnosis. So double inversion recovery faded away. And there has been another epoch when we become more interested into the leptomeningeal enhancement. Leptomeningeal enhancement again starts to fade away. There is again one good reason, because they are not specific. First, if I had a conventional MRI with a leptomeningeal enhancement, that's for God's sake not MS. That's end of a story. So that's not MS. That's not happened in the conventional scan. If you had an advanced scan to pick up leptomeningeal enhancement, this happens with inflammation, happens with later scarring. So that's not very specific in MS and tends to occur very late. So the pickup rate, conversion from bench to bedside was poor. What really survived is paramagnetic REM. Paramagnetic REM consistently happened in a pathology. We were able to confidently pick it up in the MRI sequences, reliable scans, advanced scanner. I'm a bit critical to the everyday practice of how we would pick up pearls, yet it's still very difficult in the heart of London. I presume it would be difficult everywhere. But still, this survives. This provides a genuine way to make a diagnosis of MS, and that's why it reached the criteria. Not double inversion is broadly mentioned now, but it's what really survived is a paramagnetic REM. I wanted just to highlight maybe a bit of a background why paramagnetic REM specifically and not the other things. So the translation from bench to bedside hasn't been great. But back to our everyday practice. Again, for my little brain, I made this cartoon. There are, you have 3 different colors here. So these are all these patterns. You know the MS pattern. Now these are the non-MS pattern. So the non-MS pattern, so for the gray zone, which is very common, that's called no man's land. No man's land because it happens everywhere. And it is actually the watershed lines. So it can happen in every single pathology, happens frequently in patients with migraine, happens with patients with blood supply problem of various types. If you have a vasculitis, that's a blood vessel disease, and the surface of the brain has the most area of blood vessels. So it tends to involve cortical predominance in the surface of the brain rather than to the core of the brain. The core of the brain has 4 to 12 lenticular striate branches. The largest is Charcot artery. So but there are 4 or 5 to 12, and they are anterior penetrating, posterior penetrating, but that's the whole area of blood supply. The more abundance is on the surface. To cover the whole cortical mantle, you need a high surface area of blood vessels. This is where, statistically, you would end up with a pathology of a vessel. You would have more of an abundance in a subcortical pattern. And the deep core is again, from the fact this is how the brain develops. So we start with the periventricular, we start with the main trunk of an artery, and as the brain grows up, the caliber of the artery is not graded. So you would end up from a large trunk, internal cerebral, T carotid, and you would end up with lenticular striate branches. So the transmission of pressure is abrupt. So that's why lenticular striate branches are more vulnerable to small vessel disease or hypertension, because the shear forces is high in these branches, and they tend to involve the core of the brain. And these are, so we have MS pattern, no man's land, vasculitis, hypertensive, or else. But these can make us survive for a good number of cases. So, for example, let's go through that case. That's frontoparietal lesion. No single lesion so far touched the cortex. I'm suspicious. Still suspicious. So again, if you switch to the intuitive brain, heart would not say MS. Still, in this particular case. But in some other cases, you would need to switch your left side of the brain, be more of a detective, have more of an identification, and you would ask yourself, do they follow the lines? Are there specific pattern? Is there a specific pattern? Are they touching the common patterns in MS? So that's simply, if, for example, if we had a little knife, peeled out everything outside that line, you wouldn't find a lesion. Still, all of them happens in the core of the brain. Let's see. So if you notice, there is a cap here, but it doesn't point towards our forceps line of MS. It points out towards the no man's land. No man's land. Okay. Temporal lobe, we had a burden of a lesion up there, but we have a clear, crystal clear temporal horn, temporal lobe. Interesting migraine. Okay, so I asked you that question in the pre-workshop questionnaire. We had a bit of a 50-50. Some of us thinks it is MS, some of us don't think it is. But that tells you how intuition can be tricky. Don't rely only on intuition. Intuition is hardwired in a brain for a good purpose. And so you should always keep your intuition around, but you should apply a left hemisphere part of you alive and kicking. And I told you in the beginning as well that we have in the perivascular spaces, we have arteries, veins, and nerve fibers. So you can have a problem with an artery, and you would end up with what looks like a central vein sign, and you would have what looks like an MRI and an MS mimic pattern. So because these white dots are actually blood channels or veins, and I hope we picked up. No, I didn't get a SWE here, but all these would show a central vein. All these would show the sensitive part of the disease. But again, if the disease speaks volume and it did not show specificity, a pearl, an oligoclonal band, a dissemination in time, you wouldn't make the diagnosis of MS. All these lesions very much tricky and can be tricked for an MS, but they are extensive. And if this patient is coming with a cerebellar gait problem, you would suspect MS. But still, again, if I had the same knife, clean that back and cut again, that happens in the core. Most of them are in the core. Some of them extends to the finger, but still happens predominantly on the core. That's a small vessel disease, but it's very much picking like MS because it is an arterial pathology. It's not the lenticular striate one. It's not the usual one. Okay. So we can have some temporal lobe lesions, but after huge frontoparietal involvement. So we have, if you compare that again, so you have some temporal, but a lot, but the burden is up there, is in the frontoparietal region. And of course, a large volume loss for that particular patient. Okay, that's a patient. It's very tricky, I think, because we have a radiologist, so some of you might be experienced it. Can you make a spot diagnosis? It's very difficult, very difficult. For one fact, you would never make a diagnosis based on a couple of slides. You would need a whole volume, have a time, have a clinical symptom. That's a very awkward way of neurology or neuroradiology teaching. I'll tell you the trick. There is no forceps major here. That's partial corpus callosal agenesis. And because the white matter fibers here follows the forceps minor and major, because they are aberrant nerve tract. They follow the MS lesion patterns, but simply because it's not just the veins that follow these pathways, it's the arteries, veins, and the nerve tract. In April, I presented this slide, and I described it as a geopolitically important diagnosis. And I should have been more elaborate in that. You know that there are two hyper intensities, arising from the cap of the frontal horn, and this called ear of a lynx sign in hereditary spastic paraparesis. At that time, the lynx has been doing a great job in Egypt. Refer back to the news. And that's a terminal zone demyelination, so some defective demyelination, but they follow the patterns simply because these are nerve tract. So still, there is no universal, undeniable imaging biomarker in MS. You need to contemplate and exercise a very good clinical judgment before making your diagnosis. What do you think, this patient? That's a tricky patient. That's difficult, but let's have a look together. Let's start with the frontal parietal. We have few lesions, some not perfectly aligned, but they are still not touching the cortical mantle in a nice way. But if we travel slightly downwards, that's more of a deep cortical. But it does not involve the core of the brain. It involves more of the external capsule here. Once you turn the external capsule, people switch their minds to which diagnosis? Cadicel? But external capsule happens in MS as well. This is just but the external capsule claustroms, or this is actually a patient with cadicel. And I'll give you another break. I'll tell you a very nice story. So I've learned something only recently. Is just so sometimes I started to prescribe my patients books, and it's a very good one. So because sometimes in the functional neurological diagnosis, they have a brilliant Queen Square neurologist and neurophysiologist wrote a book called "It's All in Your Head," and it's a very insightful book. And another book called "The Age of Diagnosis." Susan O'Sullivan. The author is very nice. And one of the things that I found really relevant to us is a very nice book. I've really enjoyed every page of it. It's called Neurocinema, and it's written in Arabic. For the fun of things, I've come to know the author for the first time here in this place 6 months back. I think he's in the audience, Dr. Ismail. One of the very nice stories I wanted to share with you is that Ismail tried to think about why Harry Potter gets a headache. So here's what Ismail highlighted from lots of experts, that it might be a nummular headache, might be a migraine headache, a thunderclap headache. But I think, Ismail, you missed the most relevant diagnosis. Ismail, you are sitting in your clinic and having a little child who tells you, I am a student in a wizardry and witchcraft school. What would be your first step? Olanzapine and psychiatry referral. Simple. Even more, you have, going through the history, you would know that this guy banged his head in one of the platforms in King's Cross, and he ended up in a school. So that's traumatic brain injury. Okay, now he gets a headache, As you take the history, this guy goes into a trance state, see people that they do not exist, and remember some facts from his age of 1 or 2 years old. You do not have an episodic memory at that part. There is a childhood amnesia for the episodic memory. You don't have a particular memory. None of us have a memory of 1 or 2 years of age. Guess what? Impaired awareness epilepsy. Is that lamotrigine, 25 milligrams, 2 weeks, increase slowly, check for allergies. That's epilepsy. The guy has impaired awareness seizure followed by a headache. That's as simple as I would think of it. But I really encourage you to read the book. It's on Abjad and on copy. And more importantly, it's full of neurological syndromes. It's very insightful. It has been very insightful to me, and I wanted to share that fact with you as well. Okay, break, continue. So we have, yes, please. Go ahead.
How would you differentiate leukodystrophies from MS?
I would answer the easy question is clinical judgment. So in clinical judgment, I would not rely only on the MRI. I would piecemeal every single thing together, put the context of the history, and try to make a theory from the MRI, pro and con, for the two diagnoses. And I would start from the pathology. That's how I would do. I would start by trying to find sure evidence of inflammation. For example, a leukodystrophy patient wouldn't show a lymphocytosis or bands. That's a sure sign of inflammation. I would interpret every other context as inflammatory once I had a sure sign of it. If he had a family history of leukodystrophy, that's a clear cut. Even if he had a bands, I would highly doubt the diagnosis. It's all about hypothesis and how to, collate everything together into one hand. So there is no MRI is very much informative, and sometimes information is not good. So sometimes there is an infobesity of things. So if you ask MRI a question, it will not tell you, I don't know. It will tell you something, but you will have to figure something. It's like pretty much like a wizard. So you would come back with an answer. So that's visual obscuration in a headache patient, and you end up with some few white matter changes or a dilated vein that looks like a cavernous malformation or not, and you would start to think, is it really the hair migraine, or this is the developmental venous anomaly? And you start to ask yourself. MRI is not a definite answer, but what's really transforming in the world of neurology now is that we are transforming into a precision medicine, and we are transforming into a fluid biomarker-based diagnosis all the time. When I started my training, I had lots and lots and lots of patients I diagnosed them as ADEM, and I give them steroids for a bit of time, and they had a variable recovery and back. Now, if I saw the same patients, I'm going to give them 5 or 6 different diagnoses based on the biomarkers. We are transforming into more of a precision medicine with the good and bad of it. But what I want really to highlight is that MRI is not an answer alone and not an answer in most cases. I teach neuroimaging. I love neuroimaging, but they are not the answer. They can help you to make the answer. They can help you to make a hypothesis, but you would always need to integrate every single fact. So the short answer, clinical judgment. True answer, that's difficult. Okay.
I have another question.
Please.
So something I didn't used to see during fellowship training that I'm seeing in the Middle East is that we have several patients who look like MS patients, and they have more of a posterior chiasmal involvement, but they look like really typical MS. So have you encountered this?
So once again, is it regarding the imaging localization? You mean? I would say it just happens. To be honest with you, what I my personal reflection is that I do have a higher volume of misdiagnoses in MS in the period that I practiced in Egypt, and even after traveling and being in contact remotely, the chance there is an overdiagnosis of relapsing remitting forms, and there is a much of a lower diagnosis of primary progressive phenotypes. For various reasons and the styles of practice makes things much easier to diagnose, and others are not particularly easier. But simply the fact is, it really just happens. And again, keep telling that in every single imaging presentation. That's so the scans are not the answer. The scan are an answer, or part of the answer, but they are definitely not the answer. They are easy, they are accessible. They can make some information out of it, but you can make quite wrong and misleading diagnoses out of the scans if you rely only on them. So that's my take, to be honest. We have less than 40 minutes to finish 2 presentations. So that's slower part of the presentations. I'm going to go faster. Okay, so that's in the Brainstem. I personally love this presentation, but it didn't get much of a vote, so I have to pretend and be democratic. So in imaging the Brainstem, the main difficulty in imaging the Brainstem is the anatomy. Anatomy is challenging, and you need to know the intricate intrinsic anatomy of the Brainstem to be able to have a better interpretation. So we need a proper high field scanner, 2 different weighted images, and for our own sake, I'm going to go through the anatomy of the Brainstem in the next, let's say, in the next 10 minutes. For every I'm going through the cross-sectional anatomy. In every station of the Brainstem, midbrain, pons, and medulla, you would find that they have 2 levels: upper and lower midbrain, upper and lower pons, upper and lower medulla. Okay, there are landmarks for every station you're in, and the main purpose for that particular teaching is to identify where exactly I am. So which level I am. There is a landmark for every one of these 6 levels, and we will simply go through them. So let's start with the midbrain. So in the midbrain, you would have two things that will be quite helpful. So there is, I think, for our own purposes, again, before I start, there are 2 things that you can rely on making you level: the CSF space and the cerebellar peduncles. Okay, so these are very, very helpful to start with, and you can build the rest of the interpretation on it. So, so the upper and lower midbrain is based on, am I seeing a CSF aqueduct, or am I seeing an upper 4th ventricle? What is the difference on a scan between these two anatomical or two ventricular spaces or CSF spaces? The main difference is that, do I see a tectile plate? Do I see a piece of tissue behind the CSF space or not? If there isn't, that's a ventricle. If there is, that's tectile plate. Okay, let's have the simple fact to start from the very top. That's thalamus, and the lower end of the thalamus. That's our fellow lateral geniculate we left off a couple of presentations back. And the thalamus, internal capsule, and the basal ganglia. As you travel through, so that's the top. So I start to see an aqueduct. That's a proper midbrain. That's not hypothalamus. There is a hypothalamus, actually, but that's not a thalamus, not a subthalamus. So if there is a CSF space, so that's midbrain. It's upper midbrain because it has an aqueduct. Okay, so going through the intricacies. So upper midbrain, I'm sorry, I'll be slightly faster. You will have the slides, so you will be able to look at them into the handout. CSF space, periaqueductal space. There is a cerebellar decussation. 2 hypo-intense eyes for the red nuclei, and there is a crus cerebri containing 2 adorable neurological structures: crus cerebri, pyramidal descending tract, and our heroic substantia nigra. And in the posterior, you would find the sensory tract. So just if you notice, that looks like the internal capsule. That's motor, and that's sensory. It's later on, as it travels up, it would show up, that difference. Okay, upper midbrain or lower midbrain, so that's the short answer is there is no tissue, so that's the top of the fourth ventricle, that's lower midbrain. It becomes even more important when you try to localize cranial nerves, for example, and CSF aqueducts, so for CSF cisterns. For example, the third ventricle, a third nerve emerges from the lower midbrain in the interpeduncular fossa. That's too much at the end. Yeah, so I wouldn't go into that detail for now. I believe you are exhausted already. But that's lower midbrain, and that's a pontine midbrain junction. Why it is a pontine midbrain junction? Because I start to show, so compared to the ones before, let's say here, so it's still fourth ventricle, but there is no link, physical tissue link between the cerebellum and the midbrain. So that's still the midbrain. When we start to find there is something that is traversing between the brainstem and the cerebellum, that's a cerebellar peduncle. Yeah, the 150 IQ question. Which cerebellar peduncle comes first? Superior cerebellar peduncle. So that should be the superior cerebellar peduncle. How does it look like? I love to imagine that as a big tooth. That's how it looks. Sorry. Yes, okay. So that's the root of the tooth is the superior cerebellar peduncle. And here is our lovable panda of Wilson disease. So in the Wilson disease, you'd have lots of gray matter involvement, sparing the red nucleus, sparing the cerebral peduncle, part of the cerebral peduncle actually. These are the descending tracts, but the hyperintensity here is in the substantia nigra, and that's why these patients have extra pyramidal symptoms. So proper pons, we would start with the sawtooth, that's a superior cerebellar peduncle, and then as we travel down, so in the upper pons, there is a trigeminal, there is a piece of tissue traversing from the posterior lateral side, traversing to the cavernous region, to the lateral side of the cavernous region, and then to the front of the face, that's the trigeminal nerve. As you travel down, we will have the proper large bands of the middle cerebellar peduncle. I asked you guys about, I hope I included that. Did I? Yes. I asked you guys about that. It's very tricky, but as it's meant to be tricky. It's not easy. But most of us answer that piece of brain tissue lesion is as a middle cerebellar peduncle. It doesn't look like the middle cerebellar peduncle. It's a sawtooth. That's a superior cerebellar peduncle. And that's a very peculiar lesion in patients with MS. And relatively specific lesion. Back to the pons. So middle cerebellar peduncle has a very large connection to the cerebellum. And importantly, we would start to show that large cisternal space, internal auditory canal, two lateral going 7th and 8th cranial nerve. Usually the 6th cranial nerve emerges from the surface. Spot diagnosis? Yeah, centropontine myelinolysis, because that's what the textbook I picked up this scan from. But it can happen in another context. The patient presenting with bulbar weakness and right side weakness, I can make a diagnosis of a stroke anyway. But it's not a typical trident, but it is it's a centropontine myelinolysis. Medulla is the longest in terms of long axis. So you have multiple slides, axial slides in the brainstem, in the medulla, and it has two components, again, in relation to the CSF space. Open medulla, when you have a ventricle, and closed medulla, when you don't have a ventricle. That's as simple as that. So there is a fourth ventricle, there's no central canal, so that's open medulla. And then there is a connection with the cerebellum. Guess what? Inferior cerebellar peduncle. So that's how it looks. And there is, again, this is 7th and 8th going to the cochlea, because they do happen, that if I pardon me for imagining that as an unfit neurologist like me, let's say. So, and you have you have a big belly, and you have most of the nerves emerge from that level or that level. So that's where trigeminal starts. Here is where 7s, 8s emerge. Middle is just large tract, white matter tract. Okay, so applying that, this is why I still see a 7th and an 8th in an open medulla, in the upper part of the medulla. As we travel down this well, you will find another anterolateral extension, but these are below the internal auditory canals, so these are the bulbar nerves. Okay, so, and that's a pica infarction involving the inferior cerebellar peduncle and a wedge-shaped infarction to the brain. So there is one fact about that MS lesions are less aggressive, are more irritative, and less destructive. And they persist. They are that types of stains on your white shirt that they would never go away. So a patient with a brainstem relapse 10 years back still show the MRI changes till today. So that lesion has recovered, connectivity are back, function is back, lesion still there. So they are more likely to find silent brainstem lesions and silent lesions than, for example, a stroke. And this is also an emerging feature in the diagnosis of antibody-mediated demyelination. So MOGAD, NMOSD, frequently involves the brainstem, but they fade away. MS doesn't. MS still keeps the same. Another important fact, if I had a stroke, tiny stroke, in a cerebropeduncle, my patient is almost diplegic. It has a highly significant paresis. Patients with MS, when in an acute cerebropeduncle, get only a form of weakness and a lot of abnormal movement, as we will see. So it's a bit of a clinical radiological pattern here. Again, for the sake of time, I'm not going to go through that, but there are two things that I will leave you for. One, in the last period, me and my team we have been interested into making a radiological pattern in MS lesions. And we described the pattern of veins. Again, MS lesions do happen around veins, do happen in veins of the brainstem. And what they simply, you can imagine the core of the CSF space. Let me just pick it up. So the core of the CSF space as the sun and the veins always radiate from that. So this is called a sun ray pattern. These are the long axes of lesions. In a small cohort, we found that 80% of lesions tend to do align. You will see that it's very visually appealing. And for the matching of the clinical syndromes, I would refer you to our recently published article. It's very interesting. I love it. So anyway, so that's you can have a pattern of what happens in brainstem syndromes, midbrain syndromes, and how they look like in the scans. Pontine and how they look like, Pontine syndromes and how they look like. They tend to show some persistence, not universal, but it tends to show some persistence. I'm going to go through them in a nutshell with you. So that's Pontine, that's, let's have a contemplation to the midbrain. That's a lesion around the periaqueductal gray matter region. Usually these patients present with exacerbated headaches and pain syndromes. Again, that's a long axis here. This lesion doesn't particularly match, but the rest are. That's another sun ray pattern. And usually the paramedian part of the brainstem is occupied by the oculomotor nerves and the oculomotor nuclei and the connecting tracts. So the patients frequently present with eye movement abnormality and frequently involve the ventricular surface of the brainstem, the level next to it. And that's again another cerebropeduncle one, or maybe subthalamic, but the patient presents with abnormal movement in chorea rather than a hemiparesis. Bilateral cerebral peduncle here and there, and the patient present with a pathological laughter rather than a quadriplegia also. And this is the things that passionate neurologists love, paroxysmal kinesogenic dystonia. That's a lesion in the crossing cerebellar fibers. It's called paroxysmal ataxia dysarthria, very, very frequent in patients with MS. For the pontine lesions, we saw the same pattern. There is a very good rule, I think most of us know about it. It says the core is vascular and the subpile is MS, and the peripheral is MS, around the subpia and around the ventricle. But now you know why, because there is an angulation of the veins and there is likely a turbulence around that part, and it's usually involving the core. There is more likelihood to be around the periphery. So that's a vascular patient, small vessel disease, and that's an MS patient. Poor quality scans, but it's just I wanted to cite the referring article, but we will see in a minute. That's superior cerebellar peduncle and another subpile lesion on the top, and that's another paramedian syndrome. Paramedian syndrome is whatever posterior midline lesions that the variable eye movement abnormality, either alone or with cerebellar or other findings. That's again a paramedian syndrome and a fascicular syndrome. I love that one because it's very specific. So MS lesions, they have very specific pattern of following the veins and the nerve fascicle of the trigeminal and the facial. So that's usually where the trajectory of these nerves and the nerve fascicles are. And it's very specific for MS. Again, the subpile pattern is somehow specific for MS. And of course, you know, the root entry lesion, these are all relatively specific to a perivent lesion, speaking. So again, that's a fascicular lesion, it's boring. And now the pontine, we would, still got 20 minutes, good. So that's the medullary pattern. Medullary syndromes are quite tricky because they are very difficult to visualize, and it's difficult for you to actually link a clinical symptom to what's happening in the medulla. Because if you have this little shadow, you would be doubtful that this is actually a lesion. So let's say here, and this is actually a lesion, and the patient is suffering a lot with lots of things. But if you look through the literature, brainstem medullary lesions are rare because the volume of the medulla is not big compared to a pons, compared to a brain, but when it do happen, it can kill a patient. There is historically a large debate that still goes on and on about if MS is a primary inflammatory problem or a neurodegenerative secondary to an oligodendrogliopathy. This debate has been sparked a lot by a medullary lesion that killed a patient. It's called Pre-MENACTRIMS lesion. So the scientist who described it is called Pre-MENACTRIMS. And I think she, not he. This was in the 70s. And the interesting thing is that this lesion caused an autonomic dysfunction. The patient died. There was no inflammatory infiltrate in this lesion, and saw a florid demyelination. So that at the time sparked the debate that this is likely the demyelination happened, the oligodendroglia faded away and elicited an inflammatory reaction. Now, I'm not aware of too many people who are still proponents of this theory, but just historically, this was elicited by a critical lesion in the medulla. We will see in a second. This is called the centromedullary syndrome. And it is there in the literature a lot. Let's see. So that involves the core of the cerebellum, of the medulla. Because the medulla is a small tissue space, and it has a lot of gray matter, autonomic centers. Lots of the autonomic centers are oscillatory centers. So, for example, respiratory pattern is based upon an oscillating cells. If you disrupt the harmony, you would end up with an autonomic dysfunction without even destructing the nucleus, but you would disrupt the harmony of the autonomic centers. So that's why central lesions are quite profound. Again, even if they are not quite destructive, a stroke in this place is a patient is definitely a Jacksonian quadriplegic, but in MS they would end up with autonomic symptoms. this patient, that's called an anterior pyramidal syndrome. So sometimes the lesions in the brainstem appears on the medulla, appears in the front on the pyramids. And this does not necessarily result in an abrupt weakness. It tends to show that frequently they can be solitary, cervicomedullary, and they can be progressive solitary lesions in that particular part of the brain. That's a peduncle syndrome because this is the inferior cerebellar peduncle syndrome, gaze evoked nystagmus and a cerebellar symptom. That's vestibular and cerebellar symptoms. And that's an anterior cervicomedullary lesion. It tends to be progressive too. Let me double check if we have a central. So I snipped up few slides from the original presentation. These guys, if you look up the case report in the central medullary syndrome, you would see stress cardiomyopathy, Takotsubo cardiomyopathy, flash pulmonary edema, fluctuating blood pressure. Make sure that if you have an MS patient who's acutely unwell, that he does not or she does not suffer a brainstem medullary lesion. They are difficult to visualize. You will need a proper scan, and it's difficult to visualize because they are not, in terms of visual relevance, they make much more sense of the lesions in the supraventricular part, and you would miss a tiny lesion causing all the problems. So I want also to highlight that posterior upper cervical. It's not actually a medullary lesion. It lies in the upper medulla. That's likely. So it's upper cervix, upper cervical cord, and can slightly extend to the upper medulla. The important caveat here is that it is in the posterior colon, and it does not reach the open medulla. This is a relevant feature that you need to contemplate when you are suspecting neuromyelitis optica, because it tends to involve that part of the brain, but the clinical syndrome is way different. So if that lesion starts to involve the open medulla, this will result in an intractable vomiting, the pretty much autonomic manifestation of the lower medulla. It would be very classically described in NMOSD. However, it's not specific to NMOSD. If it happens that a patient with MS had a lesion in the open medullary part of this, they can present with gastrointestinal symptoms. So, but it's still, if you had that posterior cord lesion, it can look like the intractable vomiting, and that's why I wanted to pick that in the pre-evaluation questionnaire, just to pick your brain. But most of you got it right. So that's sensory symptoms, posterior colon symptoms, rather than brainstem or medullary symptoms, if that's the case for MS. That's the summary of the syndromes. You'll find it in full detail in the on the review. And we will, just for the sake of time, because we only left with 15 minutes, we will go straight away to the code presentation. It will be quite quick, hopefully. Okay, any quick questions? Urgent questions? Brilliant. Okay. So the brainstem is, the code is very challenging to visualize. I originally made this slide to highlight that the spinal cord is in the size of the little finger. But in some of my friends, different countries, they told me that this sign might be like an ask for a permission to go for the toilet, which makes sense in the bladder dysfunction and the cord. But in any case, the cord is in the size of your little finger. And if you compare the size of your little finger to the whole size of the neck, lots of tissues, that's very difficult and technically challenging to visualize. And also, if you imagine the cord as a blank piece of paper, compared to a brain, so the brain would be a large A3, and the cord would be a little piece of paper. So there is no much to contemplate in the small tissue space. Large segment, long segment, small segment, posterior cord, anterior cord, central cord. So there's no much to take. But there's in the brains, in the cerebral hemisphere, we had a vein pattern, the no man's land pattern. We have been really visual and imaginary, but in the cord it's very difficult. And the surrounding tissue is artifactual. It's pretty much so when you are acquiring an MRI pulse sequences, it pretty much looks like if you're trying to take a photo and there is a lot of lights in the background, the contrast is low. So that's, for example, the fat here makes the contrast low. The bone marrow fat is different. The muscle signal is different. The code, this is primarily our interest. There is a column over there around. There is actually some movement artifacts, as we will see. There are swallowing artifacts. In the thorax, you would have heart-beating artifacts. There is a CSF pulsation, so there's a lot of artifacts. So you would need to first have a good signal-to-noise ratio. So one good exercise is to take off the fat signal. So that's a stir sequence. And we actually pinpointed a posterior column lesion and that wasn't there because of the contrast of the tissue. And you would have a small field of view. It's a very visually intuitive to say the whole code in one slide. You would absolutely get nothing out of that. If you're looking for a pen in a large straw pile, so that's very difficult to pinpoint anything. If you would like localize well, have a proper field of view to some lesions. So, for example, the lesion was there, but it wasn't visible. So that's slightly better because still cervicodorsal, but that's not still not the best field of view. If you narrow the field of view, you would have more details, and it's not just a zoom in. It is actually an improvement in the signal-to-noise contrast. And of course, you would have a high in-plane resolution. This is usually, most scanners do an axial T2, but whatever you would get, would be okay. That definitely needs a radiological input from the radiology department in this case. And we have lots of artifacts. That's a swallowing artifact, so you can think that there is something here, but actually there isn't. That's the patient was swallowing, patient not. You are confused, and here you're not. So again, that's called a chemical or truncation artifact because the flow of the signal, flow of the CSF occurs in pulse, and this pulse creates an artifactual signal that sometimes alternate. If you zoom in here, so bright, dark, bright, dark, bright, dark, bright, dark, bright, dark. So that's the truncation artifact, chemistry artifact. It's difficult because the tissue space is quite small. And you would, you would really need a contrast study, and you would need a proper fat suppression for that as well. So that's a T1 post-contrast and T1 post-contrast with fat suppression. We are able to see some tiny ependymal changes only in the post-contrast T1 fat suppression, and that's again the stir versus the T2. And have a comprehensive radiological anatomy of the spine. We wouldn't be able to do that in 10 minutes. So I'll refer you to some interesting videos in the end. So MS patterns, you're quite knowledgeable of that. The posterior colon is the most common. Second is the lateral, most less frequent, but still there, the anterior pattern. They need to be a short segment, one or two segments, and they need to occupy less than 50% of the code. That's easy. But the tricks comes when you are struggling to make a diagnosis, not after that. So that's anterior segment of the cord, lateral segment of the cord, lateral segment, posterior segment, and that's the one or two short MRI sequences. So I think, so to tell you the truth, what I'm going to show you in the next 10 minutes, I'm going to show you these fancy, colorful MRI patterns and diagnostic signs that we love as neurologists. We love to contemplate them and take, yes, you'll find them in a handout anyway. But in any case, they can't make a diagnosis. They look fancy. You're biased to them, but you would not make a diagnosis based on them. That's highly tricky. They can guide you. They can give you a clue of what's going on. They can interpret your patient's symptoms or previous symptoms, but still, to make a proper diagnosis, that's not the scan. 4 central patterns, 6 peripheral patterns. Enjoy yourself. I'm going to show you them all, but please be reminded that to make a diagnosis in a patient presenting with a cord symptom, and you have an abnormal cord finding, it is not alone the cord imaging and the patient symptoms that would make the diagnosis. You would need a contemplation of the fluid biomarkers, which are, to me, they are the most and highly relevant in spine imaging. And fluid biomarkers is the width and breadth of blood, CSF. That's all what you can think of. That includes the ESRs, that includes the ANA and ANCA. So that's everything. But fluid biomarkers would make a diagnosis. So anti-double-stranded DNA in a positive long segment MRI is lupus. Anti-double-stranded DNA negative in a long segment longitudinal extensive MRI. 2 weeks later, NMOSD positive, that's an NMOSD. That's the image appearance is the same. Bright spotty lesions, contrast enhancing scans. That's not the difference. Don't be distracted by the fancy looking signs. Know them very well because they will help, but don't stand only on these signs. That's owl's eye or snake eye. What it implies something important, that there is a pathology affecting the gray matter, likely the anterior horns of the spinal cord. That happens in ALS, amyotrophic lateral sclerosis, the cells are dying out. Happens in poliomyelitis, for example. Happens in paraneoplastic inflammatory disorders, because you're quite picky in the... get back, brilliant. So let's go very quickly. Okay, so so one, fluid biomarkers is essential. 2, the hidden diagnosis lies outside the cord. If you have a leptomeningeal enhancement for a sarcoid, that's not the cord, that's the surrounding dural tissue. If there is a MET deposit, it's likely on the outside surface. So that's what I want to give you an idea upon. So central pattern implies a gray matter pathology. Gray matter pathology can be inflammatory. How would I know that? With an acute presentation and a florid CSF inflammatory presentation. And if it is a neurodegenerative, this would be a progressive clinical neurophysiological deterioration. And if I found something that is there, I would not be panicked that I'm missing an inflammatory diagnosis. I may do a CSF with a blind cells to reassure myself, but not particularly change my diagnosis of an ALS if it is an ALS. So that's my take on that. And that's an NMOSD is a central cord presentation. It involves the gray matter. And the famous H-shaped pattern of the MOGAD, it simply involves the gray matter of the cord, but it also happens in other conditions. Poliomyelitis causes gray matter pathology, and you would find an abnormal cells, and you would say a MOG negative diagnosis, and it is actually a polio, and it's a vaccination failure issue. So that's, anyway, Beagle sign is a famous sign in Neurobechet and a few other things, but they are still an extension to the H pattern to surround the whole cord. That's a bright spotty lesions of neuromyelitis optica, and again bright spotty lesions. But there is, we will start to contemplate a nice pattern that can give you a clue to some of the cases. It's the subpile. I'm not sure if we can. Yes, okay. So we can do a pointer. So that pattern is an extension from the subpile with the contrast is to the deeper tissue of the cord. That frequently happens with sarcoid, but happens with METs. Don't over-rely on that. Make sure you are well worked up for you and your patient. And that's another neuropsychoid, neurologist's favorite, and the central pattern in the neuropsychoid. But that appears central, if you can notice here, but it's still in the lower slide, it's starts to show the subpile pattern in a small extent. But again, here is a moral. I wouldn't make a neuropsychoid diagnosis based on an imaging finding. Neuropsychoid, how to make a diagnosis of what confirms the diagnosis of a neuropsychoid? Tissue biopsy. It's a tissue biopsy. It's not even an imaging-based biopsy, imaging-based diagnosis. Thank you for the tissue biopsy. That's a trident sign of the neuropsychoid. Fancy, good-looking, can happen with a metastatic melanoma. Anyway, so but that's don't rely on that. In a metastatic melanoma, so you would do a CSF, the CSF would be bland, you would find some abnormal pigmented cell, you would find a bilirubin in the CSF, and you would find a little skin lesion if you do a PET scan, and you wouldn't diagnose that early. That's one of my patients. So that's the story, not the scan. That's again a posterior pattern. It's very difficult to contemplate. There is a spinal canal stenosis, but there is a little enhancement here. Not quite visible because of that scan is not fat suppressed, and that's a post-contrast scan because the basivertebral vein here is enhancing compared to the non-contrast. I hope we can find one last lesion for it. So that's a patient with a tabes dorsalis, posterior colon lesion, and spot diagnosis. What's that? Yes, subacute combined degeneration. Yes, it's a resurging disease, particularly in East London, because there is a habit of nitrous oxide consumption, which interrupts the pathway of the B12 and results in acute presentation that pretty much like that. Again, for the sake of time, I didn't go through every single thing. I have been running this project within MS and outside MS in the integrative neurology side, and I recently just created a list of the integrative cross-sectional neuroanatomy. In this list, you'll find about 20 lectures. They cover I wouldn't say every single detail, but it's just the anatomical. It's an anatomy-based, structural anatomy, functional anatomy-based teaching of the brain. So for the time being, they are Arabic. They are not in English. Very soon would be in English, inshallah. And I prepared for you guys a post-attendance questionnaire. For this questionnaire, you will find 15 quiz questions. They are not tricky this time. And they are made with a feedback. So once you are done with them, you'll find a feedback on why this answer is correct or why the other answers are not. Check yourself with that. And these are the handout QR, and you'll find the slides available as well. I'm very happy for you to use for education, and thank you so much. We are finished in time, which is I'm quite pleased for that. Yeah. Not exactly time, 2 minutes late, but yes, fine. Okay, I think I was told that there is an immediate event going to happen after, but I'll be around if any questions or any concerns. I'll be happy to be around.